Retroperitoneal sarcoma, RPS. Retroperitoneal sarcoma is a rare type of soft tissue sarcoma that originates in the retroperitoneum, the space between the peritoneum, the lining of the abdominal cavity, and the posterior abdominal wall. It accounts for approximately 15% of all soft tissue sarcomas. Due to its location, RPS often grows to a large size before diagnosis, making management challenging. Epidemiology. Incidence, rare, with an annual incidence of 2 to 3 cases per million. Age, most commonly occurs in adults aged 40 to 70 years. Sex, affects males and females equally. Heart pathology. RPS includes a variety of histological subtypes, with the most common being 1. Liposarcoma, 40 to 50%. Further subtypes, well-differentiated, dedifferentiated, myxoid, and pleomorphic. 2. Leiomyosarcoma, 30%. Originates from smooth muscle cells in retroperitoneal vessels. 3. Undifferentiated pleomorphic sarcoma, UPS, high-grade tumor with aggressive behavior. 4. Other rare subtypes, malignant peripheral nerve sheath tumors, solitary fibrous tumors, and sarcomas of vascular origin. Etiology and risk factors, genetic predisposition, e.g. Liefers-Menis syndrome, neurofibromatosis type 1, exposure to radiation or carcinogens, previous history of soft tissue sarcoma. Clinical presentation. RPS often presents late due to its retroperitoneal location and the absence of early symptoms. Common presentations include 1. Symptoms, abdominal pain or discomfort due to mass effect, palpable abdominal mass, symptoms of bowel or urinary obstruction, e.g. constipation, hydronephrosis, weight loss and fatigue in advanced cases. 2. Signs, abdominal distension, nonspecific tenderness, compression symptoms such as leg edema if the inferior vena cava is compressed. 1. Imaging studies, computed tomography, CT scan. Primary modality for diagnosis, helps determine the size, location, and involvement of adjacent structures. Magnetic resonance imaging, MRI, useful in assessing local invasion and vascular involvement. Positron emission tomography. Scan may be used to assess metastasis. 2. Biopsy. Core needle biopsy is preferred for histological diagnosis. Open biopsy may be required if the needle biopsy is inconclusive. 3. Laboratory tests. Routine blood tests are usually normal, but may show anemia or hypoalbuminemia in advanced cases. Staging. Staging is based on the American Joint Committee on Cancer, AJCC, TNM classification for soft tissue sarcomas. Tumor size and depth, lymph node involvement, rare in RPS. Presence of metastasis. Management. 1. Surgical resection, mainstay of treatment for localized RPS. Wide margin resection is aimed at complete tumor removal with negative margins, R0 resection. En bloc resection may involve removal of adjacent organs, e.g. kidney, bowel, pancreas. 2. Radiation therapy. Preoperative radiation reduces tumor size and improves resectability. Postoperative radiation, used in cases of close or positive margins. Intensity modulated radiation therapy, IMRT, is often preferred to minimize damage to surrounding organs. 3. Chemotherapy, generally reserved for metastatic or unresectable disease. Agents like doxorubicin and ifosfamide are commonly used. Limited efficacy in most subtypes of RPS. 4. Targeted therapy, emerging role in select cases based on molecular profiling. 5. Palliative care. For advanced or unresectable cases, management focuses on symptom control, e.g. pain relief, nutritional support. Prognosis. Overall survival. 5-year survival rates range from 50 to 70% for localized disease. Recurrence is common, with local recurrence rates as high as 40 to 60%. Distant metastases, particularly to the lungs, occur in 10 to 20% of cases. Follow-up and surveillance. Regular imaging, CT or MRI, every 3 to 6 months for the first 2 years post-surgery, then annually. Monitoring for local recurrence or distant metastasis is essential. Challenges in management. Difficulty achieving negative margins due to proximity to vital structures. High rates of recurrence despite optimal treatment. Limited role of systemic therapy in certain histological subtypes. Future directions. Development of molecular targeted therapies. Improved radiation delivery techniques, e.g. proton therapy. Role of immunotherapy in treatment-resistant cases. Retroperitoneal sarcoma requires a multidisciplinary approach involving surgeons, medical oncologists, and radiation oncologists to optimize outcomes. early diagnosis and complete surgical resection remain critical for improving survival rates.